This patient, age 8, is a 78-year-old female with a history of heart failure with preserved ejection fraction of 45% and chronic kidney disease. Baseline creatinine is 1.7. She is presenting with persistent dyspnea and lower extremity edema despite outpatient oral diuresis. For history of present illness, she was seen 1 week ago for shortness of breath, worsening shortness of breath, bilateral ankle edema, decreased oxygen saturation, and productive cough. At that time, a chest x-ray was completed and demonstrated fluid overload. She did deny having a fever. She was afebrile at that time in the clinic and denied and didn't show any signs of any upper respiratory infection type symptoms. She was instructed to increase her daily Bumex dosing for the next 3 days and initially noted good increased urinary output and some improvement of symptoms. However, her dyspnea did return and progressively worsen over the weekend, which has prompted today's return visit. She was also advised to follow up closely, so we did kind of have our plan to come in for this 1 week follow up, but then also with the worsening symptoms. So today her oxygenation is 94% on room air, which is near her baseline of 93 to 96% when she's monitoring at home, and she does remain afebrile today. Relevant past medical history for this patient today: heart failure with ejection fraction 45%, chronic kidney disease, baseline creatinine 1.7, hyperlipidemia, and she does follow cardiology and nephrology closely. Medications and allergies: no known drug allergy. She is on losartan, Jardiance, metoprolol, Bumex, and atorvastatin. For the focused review of symptoms, again, the patient is positive for dyspnea, productive cough, and bilateral ankle edema, negative for fever, denies chest pain, dizziness, syncope, heart palpitations, and other upper respiratory infection symptoms. On physical exam, this patient appears mildly dyspneic with exertion. Lung exam reveals coarse breath sounds throughout. There is +1 pitting edema at the ankles bilaterally. Again, she's afebrile with oxygen saturation of 94% on room air. So we did decide to recheck some labs, particularly interested in a CBC, CMP, and renal function testing. White blood cell count was within normal limits, which we were suspecting that this is not an infectious process, and it did reveal a creatinine elevation from 1.7 to 2, so persistent with our suspicions of the effects of the Bumex medication. We also did a repeat chest x-ray to see if there was any change from the week prior, and there was no change. So this is also consistent with persistent volume overload, and also consistent with the symptoms that she's reporting. So for assessment, this is acute decompensated heart failure in a patient with known heart failure with preserved ejection fraction complicated by worsening renal function. There is some concern for cardiorenal syndrome happening as well. Some differentials that were considered for her: pneumonia, COPD exacerbation, PE, and acute coronary syndrome were considered, but less likely given a lack of fever. No laboratory support for any of those etiologies, stable oxygenation, unchanged imaging, and clear evidence of volume overload on physical assessment. So the plan for this patient, given failure of outpatient Oral diuresing, with the rising creatinine levels, we are admitting for IV diuresing, IV diuresis and close monitoring of renal function. So she will be admitted to the floor, and we will consult cardiology and nephrology, likely initiate strict I's and O's, daily weights, and serial renal labs. So some teaching points for this case. This case highlights the need for early escalation of IV diuresing in heart failure patients, particularly with comorbidities such as chronic kidney disease, when outpatient management fails and there are signs of worsening renal function. So, thank you.